Hello there, I'm Tony Meekum. This is topic 13, multifocal radiopacities. So once again, get your study guide out and have your chart handy. So a quick orientation for this lecture, and this comes right out of your chart. We have this mnemonic CSI. So we just finished multifocal radiolucencies, where the organizing question was whether the lesions were corticated. And now we move on to the radiopaque side, multiple, dense, or mixed lesions scattered throughout the jaws. And the mnemonic is CSI, as you see here. Think of it as a crime scene investigation, because CSI sorts your suspects into three different groups. C is for common, the entities you already know, the idiopathic osteosclerosis, condensing osteitis, and osseous dysplasia, or the ECO trio from the common paradental, if you remember the CHICO acronym. So now it's appearing in multiples. That's why it's on this lecture. The S would be for syndromic, the inherited and systemic conditions, Gardner, Cleidocranial dysplasia, McCune-Albright, and Paget, and we've already covered McCune-Albright. Then the I is going to be for inflammatory and malignant, your osteomyelitis and its cousins MRONJ and ORN, osteoradionecrosis, as well as metastases. So when you first encounter a jaw scattered with opacities, first question which group you're in. Common or already familiar, the things you should be familiar with, a syndrome, or something inflammatory or malignant. The good news is we've covered a majority of these topics, and so today we're going to focus on just three from the syndromic group, and one of which could save a patient's life. And so these are the three we're going to cover today. The three diseases we haven't covered from that S bucket, or the syndromic group. We'll cover them in depth: Gardner, Cleidocranial, and Paget. Then we'll close with a few cases from other groups just to ensure you still remember those things. The common group, your ECO trio, hopefully you already have down. If you need to go back and review those, go ahead. But we'll begin with the one that matters the most. Gardner syndrome. So this is the suspect in the lineup that can genuinely harm the patient, so it deserves your full attention. This is a subtype of familial adenomatous polyposis, an inherited condition, and its clinical significance is the patient develops multiple polyps in the colon, and those polyps carry a very high rate of malignant transformation. In the jaws and skull, Gardner produces multiple osteomas, multiple dense bone islands, supernumerary and impacted teeth, and odontomas. The threshold commonly cited are 5 or more dense bone islands or 3 or more osteomas. Patients also, as you see in this picture here, can develop epidermoid cysts of the skin. And so here's the main point to retain from this topic. The jaw findings in Gardner typically precede the intestinal polyps. So a dentist who identifies multiple osteomas and dense bone islands on a panoramic radiograph might be the first clinician to recognize the condition before the colon cancer develops. That's a genuinely life-saving diagnosis, and it's the clearest answer to the question of why a dentist must interpret the entire radiograph. All right, here's an example for you. Multiple osteomas and dense bone islands throughout both jaws. And note the impacted mandibular left second molar. And note some impacted teeth here, the mandibular premolars. That combination, multiple dense lesions together with impacted teeth, is characteristic of Gardner's. Another example, this one not quite as pronounced as the previous one, but more of the same, multiple dense bone islands. And one of these has obstructed eruption of the maxillary right premolar. So the working rule is straightforward. Multiple dense bone islands scattered throughout the jaws should prompt you to ask questions considering Gardner's. So remember, not just dense bone islands, but also here we have some osteomas. And so the rule was at least 5 areas of idiopathic osteosclerosis, and I would say very distinct ones that really stand out, or just 3 osteomas. In this case, the patient has at least 4 osteomas that I can point out right away. So if you recall osteomas, that was from the toffee topic. Just a solitary osteoma is typically a leave alone unless it's interfering with function or an aesthetic concern. But in this case, you want to ask more questions because the patient could have Gardner's. And so here's the differential. Paget's also produces dense bone, but Paget enlarges and deforms the bone, whereas Gardner adds the discrete osteomas and sometimes odontomas. Florid osseous dysplasia, your callback from the common paradental, shows a radiolucent rim around its opacities, and the dense bone islands of Gardner's do not. So management of the osteomas themselves is straightforward. Remove them for cosmetic or functional reasons. But that's not the priority. The priority is what follows. Correlate with a family history of colorectal cancer and refer the patient to a physician for evaluation of intestinal polyps. You've identified the jaw sign. The responsibility now is to ensure the patient receives a colonoscopy. To notice the osteomas and say nothing is to miss the entire point of the diagnosis. And so this is really important for your patient's safety, could affect their lives. But let's go on to the second suspect, the cleidocranial dysplasia, also termed cleidocranial dysostosis. This one's not dangerous. It's primarily a recognition diagnosis. Its features are a hypoplastic maxilla, absent or hypoplastic clavicles, a normal-sized mandible, and the dental hallmark, multiple supernumerary teeth, the so-called third dentition. You also see brachycephaly, frontal and parietal bossing, and delayed closure of sutures. And so the pathognomonic finding is retained primary teeth together with multiple unerupted supernumeraries. Extraoral clues include a family history and the well-known excessive shoulder mobility. As you can see in every textbook that talks about this, they have pictures of patients bringing their shoulders together because they lack clavicles. Also consider Gardner and pycnodysostosis. That's a more rare syndrome that causes supernumerary teeth, but that one's really rare. Management of this is to remove the primary and supernumerary teeth along with the overlying bone once the roots are approximately half formed, with early combined orthodontic and surgical treatment to monitor for cysts. And here's a memory aid for this disease. If you've seen The Three Amigos, this is Jefe, who really likes the word plethora. I just imagine him looking at one of these panos and saying they have a plethora of teeth. Now, whether or not you know the meaning of the word plethora, when you see this many teeth, when it looks like almost a third set of dentition, or it looks like shark teeth, that should make you think of cleidocranial dysplasia. And another memorable example, it's always nice when one of your favorite celebrities is really vocal about a particular condition, and this is Gaten Matarazzo from Stranger Things, or Dusty, as we know him. He's pretty vocal about having cleidocranial dysplasia. In this show, they even work it into his character. He jokes about having fewer teeth. But that seems paradoxical, doesn't it? We just talked about it being shark teeth, as being multiple, a plethora of teeth, supernumerary teeth. And so why is he missing teeth early in the show? Well, that's because the supernumeraries tend to interfere with one another and often require surgical intervention just to erupt. So the visible result can be too few teeth in the mouth, even though extra teeth are present within the bone. And so this is for any of you Stranger Things fans out there. I really like this image. And on to our third suspect, Paget's disease, also called osteitis deformans. So conceptually, it's a disease of dysregulated osteoclasts, alternating waves of resorption followed by deposition of abnormal, disorganized woven bone. It involves many bones, although it might not be truly generalized. It presents in middle-aged and older patients, is more common in men. The bones enlarge and deform, producing bowed legs and enlarging of the skull and jaws. So the classic history is the patient's hat or denture no longer fits. That's what I really remember about this. An older middle-aged man who has a hat that he has to keep widening or it no longer fits, or same with the dentures because the bone is actually expanding outward. And then notice here at the end, the other highlighted text here, increased serum alkaline phosphatase. That's a great board question that always comes up over and over. Really high ALP, especially when everything else is relatively normal, is classic for Paget's disease. And now in our systemic lecture, we'll talk about different diseases and what they do to different lab values. But that's the one that really stands out, probably above all those others, is knowing that high ALP, although it can mean several things. If it's super high and the rest is normal, think Paget's disease. And on to the imaging, it's 2 to 1 more common in the maxilla. It's usually bilateral. It affects the full extent of the involved bone. It progresses throughout stages, meaning radiolucent early, then mixed or granular, or ground glass phase, and then radiopaque. So that's similar to osseous dysplasia, but it's not quite as localized as osseous dysplasia. In the jaws, that late dense phase produced the classic cotton wool appearance like we see here, the kind of mixed, it does look like tufts of cotton. So I think that's a really great descriptive term for this disease. You also notice bone enlargement with thin cortices, large irregular hypercementosis, and displaced teeth. So 2 consequences worth remembering are an increased risk of osteomyelitis and a rare association with osteosarcoma. As far as the differential, fibrous dysplasia could look very similar, right? But usually that's younger, usually unilateral, and it'll encroach on the maxillary sinus, where Paget's disease does not. Osseous dysplasia, of course, is localized to the periapical region with a soft tissue capsule, and the metabolic diseases such as hyperparathyroidism don't enlarge the bone, whereas Paget's does. Laboratory tiebreaker again is the elevated alkaline phosphatase, which can be higher in several of these other diseases. I just want to reiterate, but if that's the only one that's high and it's super just off the charts high, think of Paget's. All right, so I've showed you these pictures already, but this is the picture to have in mind for Paget's disease, that nice tufts of cotton wool. It's typically more 2 to 1 in the maxilla, but this is the 1 in 3 exception. And then also look at the hypersegmentosis here, pretty excessive hypersegmentosis on all the remaining teeth. So both of those are classic signs of Paget's disease. All right, that was a pretty quick one, but I want to test you with some cases to make sure you're still familiar with some of those remaining suspects that we didn't cover in this lecture. So take a minute to look at this and what's going on. First of all, do you see where the lesion is, or lesions, I should say? Maybe this one stands out in the mandible, very ground glass appearance of the mandible. And if that ill-defined ground glass nature makes you think fibrous dysplasia, good, you're right on. But is that the only area of a lesion? Compare the two sinuses. And the left one is largely obstructed. Where's that sinus border? That again has that same ground glass appearance. And so this is two different bones that look like fibrous dysplasia. So this was one of our polyostotic fibrous dysplasia. This is McCune-Albright syndrome, typically associated with cafe au lait spots and endocrine overactivity, classically precocious puberty, and predominantly in females. So here it involves both the left maxilla and the mandible. Hopefully you appreciated that ground glass pattern and went right away to, okay, fibro-osseous type lesion, and the most common being fibrous dysplasia. Multifocal ground glass in a young patient should bring polyostotic fibrous dysplasia and its syndromes to mind. Here's another one, a little bit hard to see in this panel, but you can really appreciate there's a difference from one side to the other. Is that just patient positioning, or is there actually expansion? Yeah, look at the size of this jaw. It looks almost multilocular, but a little irregular, a little like there's some internal ground glass appearance. But the expansion pattern is, again, classic for fibrous dysplasia. And maybe even a little harder to recognize in the sinus, but that same thing is going on. And so this is another polyostotic fibrous dysplasia. This was the counterpart to McCune-Albright. This is Jaffe-Lichtenstein syndrome. So both syndromes that cause polyostotic fibrous dysplasia, but one includes endocrine involvement and this one does not. All right, now here's our final suspect. Different images, but they're all kind of showing the same thing. And what are we seeing? Kind of that cotton wool appearance. We just finished talking about Paget's, so is this just Paget's? Remember we said Paget's typically more extensive through the jaw. What is the key sign that I see outlining the teeth here? And that's that kind of halo of radiolucency around the teeth. This to me looks like an osteosarcoma, or it looks like something that's a radiopaque malignancy. Now, if I told you this was a male patient with a history of prostate cancer, hopefully that would hone you in on the exact diagnosis. This is prostate metastasis. This one also was a male patient, history of prostate cancer. It also looks just like osteosarcoma. See that sunburst appearance in our occlusal radiograph here of the mandible? So if it looks like osteosarcoma, you also want to compare with a history and see if they have a history of one of these opaque cancers that can metastasize either breast or prostate. And so this is a female patient down here, both of these images, and you can probably guess it, right? She had a history of breast cancer. Everything about it looks like osteosarcoma. If you just focus on the ground glass appearance, it could be any of these things we've just talked about. But again, it's that halo around the teeth, that radiolucent halo that tells you this is more malignant. It looks like an osteosarcoma, but that breast cancer history is what tells us it's more likely a breast cancer metastasis. So keep those in mind. Again, really important. And so that completes CSI, our multifocal radiopacities in those three groups. Common being your eco trio in multiples. Syndromic, meaning your Gardner, Cleidocranial, McCune-Albright, and Paget's disease. And then inflammatory or malignant. Osteomyelitis with its cousins, remember those two cousins? And the radiopaque metastases from breast and prostate. And don't walk past a jaw full of osteomas and dense bone islands without considering Gardner's. Because again, that's a diagnosis that could save a life. The next topic is going to be histopathologic diagnosis. I'm still debating how deep to go into on that, so hope that I don't go too deep and keep it easy for you, because we still have quite a bit to cover. We'll see you on that next one. Thanks.